Hi, welcome to ICBT Friday's presentation today. My name is Margaret McCall, and I, along with Mary Hosbrough and Sylvie Levine, are the facilitators for this group. I also want to welcome anyone who has joined from or is watching from a recorded video on our YouTube channel. If you like what you're hearing today and you want to learn more information about ICBT, you can go to icbt.online and find out all the information that you might want to know. The ICBT Fridays presentations are produced by members of the ICBT Facebook group. These are volunteers who are willing to offer their time and their knowledge about ICBT. If you are a licensed clinician and you are interested in learning and growing in ICBT with other clinicians, you can find the link to the Facebook group on the icbt.online website. So, today, we're having a presentation by Mike Heady, Michael Parker, and Gina Abbondante on meta OCD. We're going to start by allowing them to introduce themselves, a little bit about themselves, and each of them will give a brief overview of their experience with meta OCD and some information about meta OCD. And once they are done, you are free to ask questions. You can post your questions in the chat, and we will be monitoring the chat and we can ask them for you. You can raise your hand and we will call on you. And if no one's hands are raised, you can just go ahead and jump in and ask questions. So without any further ado, thank you guys for being here. And why don't we go in alphabetical order? So Gina, are you okay with going first?
Oh, Lord. Okay.
Sorry.
Sure. So I'm Gina Abbondante. I'm an LCSW in New Jersey. I specialize in treating perinatal and postpartum anxiety disorders and OCD. I get a fair amount of clients that come in with meta OCD. One of the more prevalent obsessional themes working with perinatal and postpartum clients is the fear of developing postpartum psychosis. So I get a fair amount of obsessing about obsessing and meta obsessing and is this OCD? How do I know I'm not going crazy? How do I know that this is not something more? So I have a lot of experience with it from a professional angle. And I also myself have OCD and experienced a fair amount of meta obsessions within my own OCD content. So I got to do a lot of that work on myself as well. So I think the two together, I have a pretty good basis of knowledge for this particular content.
Nice. Well, if we're going in alphabetical order, Mike Heady, you're next.
Hi, I'm Mike Heady, actually. Sorry, Margaret. I'm an LCPC in Maryland, the co-director and co-owner of the Anxiety and Stress Disorders Institute. And I've treated OCD for a long time, so I'm sure I've run into dozens and dozens of cases of meta OCD or variations of meta OCD. Um, and one of the things I think we're going to touch on today, the three of us, is that there's a great deal of utility in using an I-CBT framework with meta OCD because it really simplifies what we're looking at. It cuts through what other approaches might have a harder time cutting through. And I think it can help us get less stuck. So hopefully we can convey that today with how we present the topics and stuck points, and of course answering questions. So that's me. And hi everyone. Thanks for coming.
Thank you. Okay, Michael Parker.
Thanks, Margaret. Mine's easy to pronounce. I'm Mike Parker, and I'm a therapist in private practice in Pittsburgh. And yeah, I'm interested in this topic in particular with I-CBT because I've been working with OCD for a while, and have seen this, this obsession in the past. But I did notice when I started doing I-CBT that I was introducing a new treatment to people that had done other treatments. And I was also noticing that sort of triggering a little bit of meta OCD. issues in clients because that brings in some doubt as far as, should I have used that old approach? What's this new approach? Is this going to work for me? So some reasonable doubts around the treatment, but then getting triggered into, do I even have OCD? Am I going to get better? That kind of stuff. And so, and then I think, just when you're learning a new treatment and then you have to educate clients on the new treatment, you're going to experience your own reasonable doubts as a therapist. And so this is a topic that when you're trying to learn a new treatment and trying to administer it, I think this will be a helpful presentation for people to figure out how to get competency with the new approach to deal with this specific issue.
Yeah, and it's interesting because there were 2 questions on in the Facebook group about meta OCD this week, and I both asked them to join us today. So I don't see any hands raised, but does anyone have a question for our expert panelist? All right, well, I have a question. I'm curious, what's the difference when you're working with meta OCD? What is the difference between the ERP approach and the I-CBT approach? How would you treat that differently? Who?
I can start us off a little bit with that one. Yeah, they're 2 totally different worlds, which is really which makes it really interesting to be working with OCD these days and learning these different approaches. But when you're in the I-CBT world, it can kind of be hard to even remember, what would I do with the ERP approach? But really, what you would do with ERP is, if I were to take some sort of strategies or concepts you might do with someone who was telling you, I'm not sure if I have OCD, or I'm having intrusive thoughts that I might not have OCD, or I'm having intrusive thoughts that I might be never getting better, never getting over this issue, I might be getting worse. From an ERP perspective, you're going to basically tell that client that, they're experiencing intrusive thoughts. And what you want to do is probably try to eliminate or reduce any response you're having to those intrusive thoughts, because that's going to make the thought stronger. That's going to make the thought worse. You're going to tell that client to not argue with the OCD. Don't even get involved in the content. You're going to tell that person not to reassure themselves. And as a therapist, you might even say, I'm not going to reassure you about this. We're going to face your fears. We're going to embrace uncertainty. Don't forget, nothing in life is 100% certain. This is just like everything else. And so you're going to go in this kind of space where you kind of circle around the doubt and the concern, and you try not to directly address it. You might even tell that client to not engage in any conversations about mental health right now. That's just going to be a minefield for you, And so, maybe I'll just start off with that. That's the kind of ERP approach as I see it. But maybe one of you guys might want to talk about how I-CBT would be different from that.
Do you want me to go, Mike? Okay. So from an ERP perspective, like a lot of what other Mike has said, this is hard to have 2 mics in the same panel with me. We talk a lot about coming from an uncertainty. We never know, how do we know we'll never know if it's actually OCD or something else. This is junk mail, that sort of thing. But when I use I-CBT for this type of thing, I am going specifically for that doubt and that process of the doubt. So I'm stepping out of that content entirely. The content is not what matters for me in that moment. It's being able to help that person identify the process that they're using to be convinced of that doubt. What's that story that's convincing them? So it's not about figuring out, am I obsessing about this, or do I actually have OCD, or is this something more, or whatever? It's really all about that piece, like just going into seeing that process, seeing all the little pieces and how OCD is tricking them and getting them to be convinced of that story. For me, that's like the biggest piece. And I do think that the feared possible self plays a huge role in ERP. That's not even something that's really given a whole lot of airtime. You know, we talk about the core fear, but the feared possible self and what they're so afraid that means about their identity if they are missing something, or if there is something bigger there, or like that's the piece that's really hanging on for them that I don't think ERP really fleshes out enough to be able to get in there.
Yeah, that's really good because we've got the ERP perspective and the I-CBT perspective here. So y'all covered that really well. And we're getting some questions in the chat. Stephanie asked a great one because I kind of was asking that myself. Is there a universal definition of meta OCD? Like, what is it? What does it consume? And that might generate more questions too, as people start to say, oh yeah, I have a client with this one.
I'm happy to field my opinion on that, which is not really. I mean, meta OCD is typically involving, as Gina mentioned, sort of obsessing about obsessing, which can be, will my obsessions ever end? It can morph into, is this even OCD? If it's not, then what is it? Maybe I have a different disorder and this isn't really OCD. Um, in all the way into like, am I living in the matrix? And more existential forms of obsessions could be captured under meta OCD. So it really depends on how you define meta, right? I think sort of it can be a sloppy category. You know, I think contamination OCD can be a sloppy category too, by the way, right? It's not a homogeneous group of people there. So what we're really looking at, again, from an I-CBT standpoint, is a doubt is a doubt is a doubt. The question is it reasonable or not? And if it's not, then it's OCD. And we can take these sort of categories that we've created and say they don't really matter that much, um, unless it's to help sort of the client um, understand their particular feared self, the particular reasons they get absorbed. Creating those categories might help them understand that better than giving them examples of OCD that doesn't make sense to them. But that's my take on it, that meta OCD is very broad, lots of variety.
Yeah. Would anyone like to add to that before we move to the next question? I think you did a good job.
Yeah, I mean, I tend to think of it in there seem to be, in my experience, two realms of meta OCD. It seems like there's the realm of what if I don't have OCD? So you're kind of questioning the diagnosis itself, and so then you're kind of engaging yourself in that diagnostic process of, what am I experiencing? Is this, and then you're getting into feared self around, am I the sort of person who might lie about this or make up excuses? So there could be a lot of different reasons you might question whether you have OCD or not. And then there seems to be almost like another realm of it, which is, am I getting better or not? Is the treatment working or not? Am I getting worse? Am I the sort of person who's just a lost cause? My OCD is so bad or so weird that, I'm not the sort of person who's going to respond to treatment. And both of those seem to be kind of like realms that people can kind of go in and out of with this particular obsession, and then take them to different places, because the idea of am I getting better or not takes you inward, like what am I feeling, what am I experiencing, what am I obsessing about, what am I worrying about, am I any different than I was yesterday? Those are the two areas that I've encountered.
Gina, would you like to add to that?
I mean, I think both of these guys did a really good job encompassing it. I do like, I guess, just building on the obsessing about obsessing thing. I think for people that have some of like the mental health obsessions, that they start obsessing about the state of their mental health, and that becomes sort of like a meta thing, like being sort of stuck inside of their own head and their own experience about what that actually is. And trying to dissect it constantly. And then that sort of evolves into, well, how do I know that I'll recover from this? Like Michael Parker had said, like, what if I'm a treatment resistant case? What if this never gets better? What if I relapse? Like, then it sort of, flows downhill from there.
Yeah, I was just thinking back to the first question between ERP and I-CBT, whether I'm practicing either of those. If somebody says, how do I know maybe this is an OCD, and starts obsessing about that, I would probably start with assurance and facts, regardless of which one. Like, this is your Y-box score. These are how we know this. And not reassurance, but assurance that this information is readily available for you, regardless of the approach. So would you guys agree or disagree with that? Yeah.
Yeah, I think that's fair. I think most people would practice that way. Like
Yeah.
once is information, twice is sort of reassurance compulsion, maybe, and asked and answered. So, we can move on from that question. So I don't think that's unique to any particular treatment model.
Right. Okay. Well, we have another question. Anne is asking about a person who has a meta-ish fear, who starts to panic and worry that they are on a planet that is spinning, which is Earth, which led them to worry it will lead them to go insane and led them to their VST of being helpless. And she's wondering if this would be treated the same as all other obsessions, such as using your senses to know that you aren't going insane and your senses can tell you that you're actually okay.
Well, I would start with the fact that they're on a planet that is spinning is real. That is a real thing. So it's less about the panic and worry about that, and more on like the focus on the level of their sanity, in this case, it gets tricky with this, because using your senses, oftentimes I would use common sense and a lot of inner sense data. But for someone that has a meta fear about their sanity, sometimes we can overuse our inner sense data or our common sense about sanity. So sometimes you might have to go and use other senses, or maybe like what other people are noticing about that person, how they're acting, that sort of thing. I would just be a little bit careful about how this person might overuse certain senses. We might have to go outside of it. So if they're checking their mental status, if they're testing their thoughts, that's all sort of like overusing their inner sense data. So you might just want to just play around with that and notice if that's coming up for that person.
Yeah.
And
I think if I can just add to that, this feels almost like an agoraphobic reaction, like feeling trapped on a spinning planet, in a spinning solar system, in a spinning galaxy, in an ever expanding universe that's speeding up, like there's this sort of trapped quality, and then feeling like you're going insane feels like a consequence. So I think that we need to be cautious of the sequence. What really is the doubt and what really is the consequence? And when we sort of suss that out, we could say what would need to be true in the here and now for you to be going insane. The fact that you're on a spinning planet's irrelevant, right? Those seem to just be sort of the misuse of some kind of cosmology information.
Yeah, and I think this kind of relates to a general issue you might see with meta OCD, which is if therapy is the trigger, if the therapist is the trigger, if the content of therapy is the trigger, you're going to encounter a lot of people who are in the bubble in session, and you've got to kind of recognize that, and that's an I-CBT concept. A little later, in the modules, you're going to talk about the OCD bubble, which is basically becoming absorbed in your imagination and kind of dissociating a little bit. And so I think sometimes when you're getting a client like that, you might have to move ahead a little bit before you normally would to identify checking and testing rituals, as Gina was pointing out, and make sure that the client is ready to learn something during the session, because they might just use that session just as a big testing or checking ritual. And when you're in that headspace, you're not in a learning headspace. And so I think you want to just watch out for a client that does seem to be absorbed in their imagination, and say, kind of ground them a little bit by what I've done in the past is I've asked people, what do you want to learn about OCD today? What do you want to learn about yourself today? And just get them into that learning space a little bit, try to get them out of the imagination. And, that seems to be helpful. But you got to kind of do almost like a ritual prevention piece that you might have to do a little bit early on in treatment.
Okay, thank you. So I'm going to jump from the chat to raised hands, and we'll come back to the chat. But Connie is the first one with her hands raised. So Connie, you want to unmute yourself and ask a question?
Hi, can you hear me?
Yes.
Sorry, I'm really not good with technology. I try and try. So sorry. My question is, how do you see this with anxiety sensitivity? I'm wondering if you could address that. That'd be great. Thank you.
I think, I think Carl has been posting in the chat about anxiety sensitivity, so there might be some ideas in there. But generally speaking, I think anxiety sensitivity is potentially utilized by the doubt process as evidence for someone, going crazy, right? Depersonalization, derealization, absorption into a story, the whole tendency for us to have these wandering minds that get hooked into stories can be used as information to support or justify conclusions of being psychotic, going crazy. Maybe this isn't OCD. Maybe I am insane. And that can support not just the doubt of the here and now, but also someone's feared possible self, that I'm the kind of person who could be insane. Look at me. I'm depersonalized. I'm dissociated. I could be the kind of person who loses control. Look, I'm depersonalized. I'm dissociated. And even the idea of losing control or being insane are all part of that same idea that somehow what's being told to me might not be real. I might have something else. I might be something else. I may never get better if I have the wrong diagnosis. And you can assess it, the anxiety sensitivity scale, the ASI-3. It's free. The TMAS is free and around. And I would point people towards Carl's upcoming podcast on the OCD family podcast in a couple of weeks.
Nice.
Yeah, I think a client who's developing a phobic response to internal sensations, it could be feelings of anxiety. It could be feeling like a little depressed. It could be, just certain thoughts, whatever it might be. There's just like, I'm trying not to have those experiences and becoming extremely avoidant. And I think all of those are things that, with interoceptive exposure, you're definitely able to get at the anxiety and the panic symptoms, helping someone expose. You'll definitely see that with this issue. You'll see people that are very much triggered by the experiences of anxiety, and you've got to kind of put together those interoceptive exposures for them. And then there's other issues where they might have more of a fear response to, like I said, depression. In that case, you might want to do a little bit more of like de-blending, where it's actually okay to be a little depressed, and a little depressed doesn't equal severe depression and wanting to end my life. So a little bit of decatastrophizing that a little bit as well. And then with the thoughts too, someone who's scared of like, don't tell me anyone else's obsession because I don't want to get that obsession. kind of thing. You're just kind of helping the person through that. The difference would be like you're not going to do an exposure where it's like, okay, I want you to think about an obsession. You know, I'm going to sit back and not do anything, and I just want you to get anxious and feel better. You know, habituate over time. I think with an I-CBT approach, you're going to be much more in a supportive role. Let's talk through if you can actually just catch a different obsession by just encountering it. Let's just even consider another obsession and let me present it to you. And let's see what happens. And let me talk you through that process and let me help you notice what's happening right now in the here and now in our session. So it's a lot. I think there's a lot of hands-on learning you're taking clients through.
So Tang Pei, which I hope I'm saying that right, has asked a question in the chat, which brings us back to the difference between normal, reasonable, and obsessional doubts, and ask, aren't such questions normal doubts or worries? These meta questions or doubts. I guess the question was, how would you distinguish a normal one from an obsessional one? I can call on someone. How would you answer that?
I mean, I think a lot of these, sort of meta questions or existential questions are normal. I think when it switches over from normal reasoning into obsessional reasoning is when people start using obsessional reasoning into it, and there's bringing in some of their feared possible self, what it means about them if they maybe can't answer the question, or what it means about them if one of these what if things happens or comes true. I think that's sort of like the line, but yeah, on the surface, I think this question popped up after when we were saying, questions about treatment response. What if I don't respond to treatment? What if I'm treatment resistant? What if I never get better? I think those are normal questions that come up for anyone in any, not even just in OCD, just in any sort of mental health treatment, because it is a really vulnerable place to be struggling with your mental health of any diagnosis and the fear that it might not get better. So yes, on the surface, it is a normal question. And I think in particular with people that have OCD and meta obsessions, it kind of gets twisted and more convoluted, and it pulls people back into that process. So it's not necessarily about saying, oh, this is a normal worry or this is a normal obsession or whatever. It's more about like, we have to get in and see how that question is then sparking the person to get back into that obsessional narrative and that obsessional sequence. Because, really on the surface, any OCD content is pretty neutral. It's just how that sort of tricks that person to kind of get right back into that process again.
Excellent.
If I can add to that, you know, if we zoom out and just sort of consider all questions about OCD and obsessionality from an I-CBT standpoint, one of the first places we want to start from is an obsessional doubt and all of the reasoning devices that lead to its conclusion is inseparable from the narrative. It's inseparable from the narrative. So we have to understand the presentation of your client from that narrative. We can't take a Polaroid of a single part of that narrative and then go, is that OCD? Because maybe it's not. We have to understand the context of how this arose within the story. It could have been a consequence. It could have been a trigger. It could be used as a justification to support a doubt that we haven't seen yet. So we really need to zoom out and say, whether or not I'm doubting if the treatment's going to work may or may not be obsessional. We don't define that by content. We define that by where in the story it shows up. And if it shows up as an actual doubt, what made that doubt relevant or not relevant based upon those reasoning devices being used. If someone's like, I've been in treatment at Rogers for 3 months and my Y box is the same and my quality of life is the same, and I'm still struggling just as much, I have no more insight. Is treatment working? Is a completely reasonable question. If someone's never started I-CBT and they go, is treatment working? Well, it's a little early to ask that question, isn't it? So again, I think it's important to sort of not zoom too far in, slice a small piece of the client's experience out, and then ask if it's obsessional or not. We have to consider the entire narrative in context.
Yeah, I think you also want to watch out for where's the doubt taking the client, and oftentimes it's future oriented. So I'm never going to get better. I'm going to get worse. I'll never stop worrying, things like that. And then they're spending all this time in an imagined future. And if you're noticing that, that's obviously obsessional doubt. And the answer is always in the present, here and now. And that's a little tricky to do when you're first learning I-CBT to remember to do that. But I think as much as possible, you want to say, how do you resolve, the doubt, will I ever stop worrying? You actually can resolve that in the present moment. And you look at specifically, what is the client worrying about right now? And do they have any agency, like in this moment, to figure out what to do about a worry or to figure out what to do with their attention? And the client's often not doing that at all. So if you prompt a client to say, like, well, can you stop worrying right now? Or, are you able to decide what you pay attention to right now? The client can actually, shake themselves out of the doubt a little bit and bring themselves into the moment and say, yeah, I can do that. So you have to be careful not to, as the clinician, kind of believe that the client doesn't have any agency, doesn't have any ability to control their mind and their thoughts and their attention, and keep the confidence going in yourself that your client's fully capable of these things, just like anybody else, as long as you can kind of get them back in the present moment right now.
These answers are really helping me with some of my clients. Thank you. So Susan, you had your hand raised. Did you get your answer already? You did. Okay, so we'll go back to the chat. I don't see any other hands raised. Renee Levine says, in line with the overuse of inner sense data Gina was talking about, how would you use I-CBT to get at the symptoms of derealization and even depersonalization that meta-OCD can bring up? I can imagine the patient ruminating, going into the imagination regarding the physical sensations. How would you go about using reality sensing here? Or are there other modules you would prioritize when working on this? It's a long question, but you can see it in the chat. So I'm just going to call on somebody in backwards order. Michael, would you like to answer that?
I'm reading the question. Maybe
I know, right? It's long.
I'll take a stab at it. I hope I didn't misunderstand the question because I didn't read it. But so if someone's experiencing sensations like depersonalization, is that what one of the sensations was that was being described? Right? How would I-CBT try to explain it or understand it? I-CBT wants to put it into its rightful place in the story. Is this being used as a justification to support a conclusion, like I'm depersonalized, therefore I'm crazy, or I'm prone to losing control? Or is it a trigger or a prompt that leads to obsessional doubting? So much like we would try to explain the groinal sensation to someone who has pedophilia OCD, we would want to explain depersonalization from for those people. So I think we have to give people proper answers to normal physiological experiences. So I might say, depersonalization can arise for people who are hyperventilating. Depersonalization could be a completely normal experience that you are hyper aware of, attending too much to and making too much out of. But it is fundamentally a benign experience. And it's not specific to any particular issue. And that it's being misused if it's being used as sort of a out of context fact, or it's triggering you into a doubt that was already something you felt vulnerable to. So think of it as how you would explain a groinal response to someone, or other physiological sensations or bodily sensations that are being misused as justifications for a doubt or triggering people into a doubt. I don't know if that's kind of a broad way of answering that question.
Okay, I'm gonna pause for a minute. I see that Gina is back in the group. Mary, she somehow got unspotlighted.
Okay, thank you.
Uh-huh. Okay, so we have our next question. I don't see any hands raised. Any other tips to help a person get into a learning position if they're using sessions as part of their ritual? I think Gina may have spoken on that. Somebody mentioned using sessions as part of their ritual. Maybe it was Michael. I don't know.
I think any therapy can be used compulsively with people that have OCD. So I would just kind of be on the lookout if I have someone that's like trying to speed through the modules or is like not taking the time to like really understand how all of these pieces sort of stack up together to create the bigger picture for what we're doing here. Or if I have someone who's just going through the modules and doing everything sort of on the surface, taking it as like, well, this is the content that we're working on today. We're talking about, the fear of possible self, and today we're talking about the real self, but they're not seeing how all of these things sort of weave together. Generally, for me, that's sort of an indicator that somebody's just trying to rush through to the end and be like, okay, I'm done. I should be cured by now, or I should be good by now. So if I have someone that's doing that, then I'll sort of slow it down. And I always, I mean, people probably get tired of me saying this, but I always go underneath whatever the idea or the module is that we're working on that day. It's always about getting underneath of that and seeing the inferential confusion process. So really trying to front load some of that information in the beginning, doing a lot of psychoed, and then sort of like introducing some things to clients I think can help sort of create a little bit more of like a learning position rather than just like I'm zipping through to get it all done.
Yeah, that was really well said, Gina. I've borrowed a version of that from Sally and Carl over the years, which is that if and the client will tell you if you ask him this, like, what is your agenda with doing this in any given moment, at any given time of therapy? What's the agenda? And if it falls into the category of getting rid of or controlling this experience, it's probably being misused, because I don't know any therapy that is saying we're trying to control and get rid of something right now, right? Therapy is about learning, which means it's deliberate, contemplative. It is curious about the process. And if you can't orient yourself towards being curious about this new thing, like Michael had been saying to one of his clients, what do you want to learn about yourself today? What do you want to learn about OCD? It's a great sort of prompt. I'm going to steal that from you. And to really get them in that position, because if they're in the agenda of getting rid of, controlling, escaping, anything we do is likely to be seen through that lens. Like, oh, this is the secret handshake. This is how I get rid of it. And that's obviously a problem for all therapies.
Hey, Michael, would you like to add anything?
Yeah, I would just say testing the learning with the client, asking them to put it into their own words, repeat it back to you, asking them to maybe apply a concept to themselves. You can really actually, this kind of touches upon another issue, which is sometimes we have clients that are not very verbal. They don't talk a lot. They have very short answers to things. That could potentially be someone who's trying to avoid the content of what you're talking about, trying not to go too into it. So as much as possible, reminding yourself that you really want them to be doing more of the talking. You want them to kind of, prove to you that they're kind of like processing it or learning it, and able to apply it.
Right. And I'll just, if we have time at the end for any of you who have asked questions, we can allow for follow-up to your questions at the end. So Magda Rodriguez, I just say Magda, can you talk more about how you manage a client engaging in compulsions in session? They keep getting pulled into the bubble. Specific strategies would be great. Thank you for sharing your knowledge and experiences. I appreciate your time.
I'll jump in. I think it's probably pretty useful in that moment to sort of point out to the client how you know they're doing compulsions right now, because a lot of it might be mental and you're not like, they're not getting up and cleaning things, right, or organizing things. They may be, but a lot of it's probably mental. And you can see how they've disconnected from the room, how they've disconnected from you. And you can simply point that out, be like, can we hit the pause button here? I think you're somewhere else. I think you're doing something else. It's like texting and driving. I think you're texting and you should be driving. You can't do both well. So if there's a way for us to sort of bring you back, if they're really wrapped up in it, I might have them do a grounding exercise, like, hey, follow my voice back here. Don't go to the light, come back here. That was a poltergeist reference if you didn't get it. And then sort of, let's see if we can have you use some of your sensory information to ground you in the here and now. And then once I feel like you're back, then I might start seeing if we're in a place that we can start talking about this, or we might have to start going off theme so that I don't just throw you straight into the bubble again. And that might be a useful strategy. So remember, off theme, if the client's constantly being propelled into a place where they can't connect with you anymore, point out to them how you know that they are leaving the room. See if you can't get them to come back. I like to use humor, get them to laugh. It diffuses them from whatever they're in. Ground them, and then start over.
This also sort of feeds back into the earlier question about someone using sessions compulsively, but I just had this happen earlier today, so I feel like it's going to be helpful. Is if I had someone who really came to session and was triggered and really wanted to use that trigger in session and wanted me to give her reassurance. And she kept saying, well, I really want to use this. Can we use this today? And I was like, no, we can't. We have to use another topic. And she got really irritated with me, but I knew what was happening. I knew what she wanted me to do. She wanted to like figure it out. She wanted to use I-CBT to figure out whether this was OCD or not, or what she should do, or what her next step should be, or should she Google or whatever. So she was using the sessions compulsively and also using me as like a way to co-compulse with her. So that's just another way. If you have someone that comes to session and you know that they're like coming very activated or very triggered and they want to use that content in that moment, sometimes you have to be like, let's put a pin in that. We can always come back to it, but let's work on this angle or this thing that we were working on or whatever I gave you for homework, just another thing, like I find that if someone comes to session and they have like a sense of urgency, that also is another indicator for me that they're wanting me to co-compulse with them and using sessions in a compulsive kind of manner. So that's just another thing that just happened earlier today. So I figured that was a good example as well.
Those were really good responses in it. And just as a follow-up question, like for the entire audience, what are ways that you will know somebody's compulsing in a session or using the session, or what are they doing? What will you see in a session if someone's doing that?
I think you might feel yourself being put in a fully just authoritative position in session, and you're the giver of knowledge, and the other person takes it in and feels better when you give them the information. I think you want to shift a little bit when that feels like it's going too far in one direction, and make sure that the client is also claiming what they know and what information they have available, and they're bringing that into the conversation as well.
Mhm.
I have like a really simple, perhaps unhelpful response to that question, which is ask them and they'll tell you. I've never had a client not know, right? Even clients with like ridiculously overvalued ideation, like they know that they're doing a thing we call compulsions, even if they don't agree with it. Like, are you doing that thing again? And again, I try to bring in humor if I can, because I think that immediately sort of pulls them into a different area of processing. But yeah, just ask them. I think they can tell you. We don't have to come up with an ever-growing list of tricks to sort of psychoanalyze little things. It's helpful. I think all of Michael's ideas are great. But I'd say, do you think you're compulsing right now? What makes me ask that question would probably be that something changed in what we were doing, right? Like something changed. I felt you were disconnected, and that little sort of nonverbal cue, I think we all pick up on most of the time.
Right. Okay, we'll go back to the hand raise. So Lori has a question. Lori, you can unmute yourself.
Yeah, can you hear me now?
Yeah.
Okay. I'm really fascinated by this notion of not using the content that they're urgently trying to address, because I am always really tempted to do it because they're really motivated and they really want to, it draws them into the process if they can apply what they have been learning to that situation. But I'm wondering if I'm getting hooked, and because there's certainly a part. Well, I'm probably going to say, yes, this is just like your other kinds of OCD. Let's look at it, and I've just done the job of reassuring them and categorizing it. So I'm just interested in how to think through that process.
Okay, I probably should have put an asterisk in there of like, it's a maybe, maybe not. Like sometimes clients can come to sessions and you can use the like relevant trigger of that session. And sometimes you can't. I think it depends on a lot of things. I think their window of tolerance is a big one. I think where they are in their I-CBT journey or their OCD recovery journey is another one. I don't want to say it's like a hard and fast rule that if someone comes to session with a trigger or like really activated about something, then I'm gonna be like, nope, we're not using that today. Like sometimes I will, it just kind of depends on the situation and the person and, whether the sun, the moon, and the stars are all in alignment. There's all these things that sort of like factor into that. So if you have someone that can tolerate it and can use what recently came up for them, awesome. That's great. It's fresh on their mind. They don't really have to like pull on their memory too much. But then you might have someone that they just can't go there right in that moment. And that's okay too.
I think I'm not sure I can go there. I mean, because I get hooked. And
Right.
if I'm answering their questions, then I'm not using it properly. So maybe I need to do the work and then figure out if I can help them use it.
Yeah, we love being helpful and productive, don't we? Like we want to jump in, and I think we can get confused when a client is saying they're motivated or acting motivated. I want to find out what they're motivated towards, like motivated to escape how they're feeling, or motivated to learn. And those feel like two different states. And I think if you ask, they'll tell. Are you motivated to learn? Or are you motivated to, try to play whack-a-mole with your OCD today?
Taking notes, Mike. You guys are great. All right, we've got a follow-up question about the spinning on Earth. Would you treat the fear as a phobia or as OCD? It seems as though the fears are more OCD based, as the OCD worries keep jumping around, but all lead to the same place, which is not being able to handle their emotions. Don't know if you remember the original question was about I'm going to go crazy because I've realized I'm on this earth that's spinning, right?
I mean, my personal answer to that question is like, you can't know until you know, do some of that work. You kind of have to say, is there inferential confusion here? Let's find out. Tell me the story. Let's look for the inferential confusion. And if there isn't around that particular doubt, then I might go down a different road. So again, I think it's potentially problematic to take the look at the content or even sort of like how OCD is thought to act. OCD jumps around from themes. Therefore, this is jumping around, so it must be OCD, right? We don't, at least in I-CBT, we don't want to define OCD by its act or its content. We want to define it by, is there a clinical level of obsessional doubting that's driving everything that comes after this? And we have to figure that out through the story. So I hope that's not an unsatisfying answer.
Okay, ready for the next question in the chat? So this is from Sylvie. In meta presentations, when the client compulsively ruminates to figure out the meta answer, they can become fearful, even terrified of thinking and asking themselves any question. Could you share how to address this with I-CBT? So it sounds like a lot of avoidance, maybe.
Yeah, the client, I figured I'd clarify.
Sure.
That actually happened with one presentation I had of one client, and this particular client was very afraid of doing any kind of thinking because they wonder if they're going to end up trapped again in the cycle of rumination that they have been visiting all this time. I was just curious. I basically went back to the obsessional sequence. I was just curious to know if anybody, and eventually it resolved, but I was wondering if this is something that could be helpful for people to hear and how others would handle that.
One thing I would start with would probably be that idea of going deeper. Sometimes a client has been tricked by their OCD into thinking truth is something you only find by digging deeper and deeper and deeper. And a lot of times with I-CBT, we're saying, well, a lot of times the truth is like just on the surface. It's really easy and it's immediate. And so, I sometimes do a grounding exercise where I'm just asking someone a bunch of questions to have them, provide me with the immediate answer. Are you wearing shoes right now? Are you, what color is your hair? Whatever it might be. And just looking for those immediate responses. And then just helping clients see like, the truth is often very simple. You don't have to go deep. So that's just the first thing I thought of.
A real quick suggestion is the selectivity of this.
Mm.
The client's clearly not afraid of all forms of thinking. They're afraid of some form of thinking in this context. So why aren't you afraid of all forms of thinking? Right? Right. I mean, you're thinking all the time, whether you like it or not. Right. So there's a selectivity that's parsing out these kinds of thinking processes from all the rest of the thinking. And I would say that that's like 1% of your life. The other 99 you're totally fine with. You don't even think about it. How are they different? How did you come to sort of parse them apart? So I think it can get sticky to think about, I have to do a thinking treatment for a person who's afraid to think. That feels like a problem. It's like they're not afraid to think. They're getting wrapped up in thinking being a problem in a selective way. And I would just point that out.
Okay. So Carl has a question. Oh, Gina, were you going to answer or add to that?
No, that's okay. Everyone covered it.
Okay. All right. Well, Carl had a question, and we're already at 156, and there are still questions. I imagine if these questions get posted in the Facebook group that they might get an answer from some of the presenters. I don't know. But Carl's asking, how would you address iatrogenic doubt about diagnosis? For example, my psychiatrist or other therapist thinks I'm just a worrier, or you don't have ROCD, you're just in the wrong relationship.
My standard answer to clients about this is if it walks like a duck and talks like a duck, it's OCD. So following it has inferential confusion or they experience inferential confusion, and we go through all the steps, like, can we do a doubt sequence? Do you see where this what if maybe could be thought is taking you out of reality and into your imagination? Is this comprised of over-reliance on possibility, distrust of your senses and self, and their irrelevant associations? If you've got all the things, this is OCD, and what they do with that, what their level of buy-in with that is kind of on them, but that's sort of my standard answer for most people.
Yeah, I don't need to live and die on the hill that they agree that they have OCD. I'm much more interested in, do you agree that as I'm describing this way of reasoning, that that's what you're doing? Can you have enough connection to reality? And then what we call that, I don't care, because either that's a helpful way of reasoning or not. But so I think in addition to Carl's question is what if you have a psychiatrist who says I'm an OCD specialist and says you don't have OCD, and then you, a therapist, says you do have OCD, and now there's a lot of dynamics happening here, including a call to the psychiatrist, and we certainly don't want to get into a trust me, don't trust them splitting kind of behavior. So that's when I might sort of shift into, I'm trying to treat this really specific reasoning process. Do you agree that this is the kind of reasoning you're using? And let's not worry about what we're calling it just yet.
Okay. It is 1:59. And we have a long question here, but I'll tell you what, we have a short question. And Susan, we can see if we can get that question answered in the Facebook group. What is the proper frequency if someone wants to do intensive I-CBT? A little off topic, but maybe you can give your opinion on that.
I mean, I personally right now have someone doing intensive I-CBT. I see her twice a week. I've gone up to 3 times a week if someone really needed it, but that is a big asterisk of making sure that they are not coming multiple times to make sure that they're not coming compulsively. But for me, I see this person twice a week. I see them in the beginning and then the end. And that for me has worked pretty well. But I think I have known other people that have done more proper IOP type services where they'll see them 2 to 3 times a week for 3 hours, and that worked well for them as well.
Okay. Well, I am going to wrap up the meeting. I really appreciate everyone who came. I especially appreciate the presenters. I certainly learned a lot today. I hope you all have a great weekend. Thank you.